Hi, I'm Loretta Nastoupil from the University of Texas MD Anderson Cancer Center, and I'm here today at the Lugano International Conference of Malignant Lymphoma. I'm joined today by my colleague,
Peter Borchmann, hello. From Cologne, Germany. I'm head of the Lymphoma program at the University of Cologne in Germany.
We've been tasked today to try and discuss what's new about CAR T-cell therapy and give different perspectives in terms of the U.S. versus European countries. So in the U.S., we've had 2 FDA-approved products for the treatment of adult patients with large cell lymphoma for the past few years, and there have been differences in terms of uptake with standard of care CAR T-cell therapy, and we still have access to clinical trials because there's still a number of important clinical questions that are underway. And there are unique differences in practice patterns that are emerging as a result of having this new therapy available for chemo-refractory patients. But it is something that is dynamic, and we're having to learn about identifying appropriate patients for CAR T-cell therapy. There are new referral patterns that are emerging. For instance, do you refer a patient to Anderson Transplant Center or the Lymphoma Center? So those are the unique barriers or aspects to my day-to-day.
So I have some more to add, actually, because the question was for me about the rise of CAR T-cells in Europe, and then the first very important issue is that there's no common rules in Europe. So this is country-specific, and I can't really answer that question. It's very different. So we have the EMA approval for Europe. But if this is implemented in the countries, it's very different today. So there are some countries in Europe where you can't get CAR T-cells at all, and others were early on and you could just prescribe them. But what I think is common about in all countries in Europe is that due to the price of these new products, there's some efforts from the authorities to control the prescription and even to control the indication. And this is very much different from any other drug so far. And in looking at it from a European perspective, this is different in all the different countries. And so there's no common rule. In Germany we have been lucky, so we can prescribe both products that are approved. But on the other hand, there's restrictions in terms of indication, which is controlled by the insurance companies. So it takes a while unless you can really prescribe the drug. With this, in this situation, most patients are rapidly progressive, can really become a problem. And the same is true then for the referral patterns that you have mentioned. We experience the same, let's say, problems because it's just not established. So it may take a while unless we see the patients, and they have received in between a 3rd or 4th line even. So we get to see many really end-stage patients, and identifying those with the highest benefit is, I think, still important and needs to be somehow trained for everybody. So we get to see the patients earlier on.
Oh, I absolutely agree with it. I think early referral is critical, and we also have trials right now enrolling looking at first relapse versus intensive salvage chemotherapy, high-dose therapy, and those are important studies. So I also, when I have the opportunity to discuss with our referring physicians, that if you have any patient with relapsed large cell lymphoma, get them to us as soon as possible. I think there's been criticism about the phase 2 studies and the intent to treat population, that these were highly selected patients that you could enroll on trial, and so maybe this doesn't reflect what is reproducible in the real world. For instance, we have some experience now with standard of care CAR T, and what's interesting, though relatively short follow-up, is it looks like the safety, the efficacy is quite comparable, at least with axi-cell, to what we saw with ZUMA-1. But there are unique aspects, even in the U.S., particularly Medicare patients or patients who may not have optimal private insurers. As you mentioned, the length of time from requesting CAR T approval to actually having financial coverage where you can move forward, and then accounting for the manufacturing, it raises new questions about how do you stabilize these patients? Should you bridge all of them? What bridging therapy do you use? Because as you mentioned, oftentimes they're already chemo refractory. And then how can you select out patients in terms of enhanced efficacy, but also safety? Because as you mentioned, the cost of this is not minimal. And so if we could do a better job selecting out patients where we have less toxicity, better efficacy, then I think all parties would be more comfortable with this being common practice.
Do you, by chance, have an idea how many patients have been treated in like outside clinical studies in the US?
So at ASH this past year, we had a collaboration of 17 centers, and these were all standard of care, axi-cell, and we had 300 patients that were treated, and these were patients that were leukapheresed as of August of 2018. So obviously there have been more patients since that time, and as Kymriah has more uptake in the US, those numbers will increase. Though you could look at the numbers of chemo-refractory large cell lymphoma patients and say it's probably still underutilized for all of the issues that you've raised.
When comparing these numbers to the European numbers, so the largest population published so far is 60 patients from France. And certainly we have less patients in Germany. So what we clearly see is that we are way behind the US regarding CAR T, so that's the way it is. And what's about the allogeneic transplant in this setting? Because this is truly a sometimes tough debate in Europe. So should you go for allo transplants? And this is the only method that is known to be curative in intent?
Sure. I think that's a great question. I think it will still be debated. We have far more years of experience with allogeneic stem cell transplant than CAR T-cell therapy. And I think there is a different answer if you're talking about pediatric ALL as opposed to large cell lymphoma. We have now about 27 months of published data with ZUMA-1, and we do see some stabilization of those PFS curves and the durability of CR. So I do think it is a definitive treatment in large cell lymphoma. Now, I think it cures about 40% of patients, so there are still 60% of patients that are not cured. And so I still think there is a role for allogeneic transplant, but my personal opinion is it should be reserved for patients who fail CAR T-cell therapy. The benefit of CAR T, it's a one-time therapy. Now we do see B-cell aplasia, and we do see prolonged cytopenias and risk of infection, and even in some small cases, treatment-related MDS. But in general, I would say, in my personal opinion, it's probably a little bit more, it's easier to administer than an allogeneic transplant where you're dealing with chronic GVHD. So I don't think that allo transplant is gone from the discussion of treatment of large cell lymphoma, but it probably has now been moved beyond CAR T-cell therapy in the US.
As I said, in Europe, this is not yet finished, this debate, and yeah, I think this has also an impact on the referral pattern, because usually these patients have been sent to the transplant unit, but not in all cases the transplant would also apply the CAR T cells, administer the CAR T cells. So this is there's sometimes some confusion how to treat these patients right now, and it still has to be established at least in Germany, I would say.
And that's probably true in the US as well. There are clearly differences in practices, and Anderson is one center where you have disease-specific clinicians that are prescribing CAR T-cell therapy, and other centers you'll have transplant or cellular therapy specialists where you may have a lymphoma doctor refer them to their transplant physician. And I'm sure there's a more in-depth discussion if you're a transplanter about allo versus CAR T. If you're a lymphoma doctor and you're biased towards chemo-refractory patients, then you're probably going to be more in favor of CAR T-cell therapy. So I think those biases exist, and they're hard to tease out in a clinical trial. I think the randomized trials in the early relapse setting will be very interesting to see the toxicity versus the efficacy as you move it into earlier lines of therapy. And there is also a big push to try and understand mechanisms of resistance, because again, 60% of patients are going to fail, and so how do we salvage those patients? How do you get them to an allo transplant? That's a big challenge.
And just a question from my side, because within the EMA label it has been stated that all the patients treated must be documented in the EBMT register, but so far this is not really set up. Is this different in the US, or do you document
So that's
all?
a great discussion. So there's been a consensus that these patients should be captured in the CIBMTR. Now that puts a great burden on centers in terms of resources and data capture, and these patients will be followed the duration of their life. And again, if this is curative therapy, we're talking about many, many years. And so that now creates burdens in terms of capturing the data, reporting the data. I think it is at least a step forward that there is a consensus on what data should be captured and where it should be reported, because prior to this, each center was capturing their own clinical data, and the variables that were captured were obviously different across centers. Some centers were reporting adverse events directly to the sponsors, some were reporting to the FDA, and so again, this now provides a consensus on where to report bad outcomes. So I think that helps, but it does create burden on centers that are resource strapped. And so again, if you're...
There's no reimbursement right now for...
No, not for data collection. So this now raises a lot of interesting questions. If you're an administrator of a hospital, what is the feasibility of administering a tremendous amount of CAR T-cell therapy? So it's costly. That is now pushing centers to try and explore outpatient delivery of CAR T-cell therapy, which is a new dynamic and raises more questions. and may then push the preference to a better tolerated CAR T-cell therapy or construct, or at least one that can be safely administered in an outpatient setting. But there has not been good reimbursement strategies to capture the back end in terms of safety, data collection, and reporting.
And also for me to learn, what would you say right now? How many patients have been treated in an outpatient department right now?
So it's center specific. So specifically at MD Anderson, as of today, we've not treated any standard of care patients outpatient. Now that will change
because
in the next 3 months.
It's in the label. It's been said that you should keep them for 2 weeks.
Well,
that's the way it is
in terms of the construct, there are differences. So for instance, CAR, we do monitor them for a minimum of 7 days in the hospital, though in our experience on average it's about 2 weeks. For the Kymriah product, actually it's not mandated. So you could actually treat these patients outpatient. Now that's center specific in terms of staffing and availability or patient access to 24-hour emergent care. And so again, each center is having to revisit their staffing models and their structure because you want to provide effective but safe care to these patients. The CAR product that is currently in clinical development and is anticipated to be FDA approved next year might be the most, it might be the product that can be administered outpatient the easiest or safest way. And so there is a big push to try and get your center set up to do this.
Yeah, because that's another problem for us right now. So we have to keep the patients for weeks, and even if they don't have any fevers, anything.
Right.
And we don't have millions of beds.
Correct.
So the more patients we treat, the less flexible we are as a clinic to treat our patients.
This is true.
So this is also something we have to learn how to handle this, how to manage the situation, right? And it would be easier if we could administer this in the outpatient department. But right now it would be forbidden simply, so it's no way.
And I think those raise still important questions that need to be answered. What does your staffing model need to look like? Is there a preferred construct that is more safely delivered outpatient but maintains the efficacy? And as we move this into earlier lines of therapy, numbers increase in terms of patient volume. So again, this is an interesting time. It's rapidly evolving, but we have effective therapy for patients that didn't exist 5 years ago.
So true.